Good morning. My name is Lillian Muli and I trust you're off to a good start of the day. This morning we shine a spotlight on the world of orthopedic and trauma surgery. From the split-second decisions that save lives after devastating accidents to the long journey of managing chronic conditions like arthritis that affect hundreds in this country. Joining me in studio is Dr. John Kenywa, an orthopedic and trauma surgeon, to unpack the realities inside the emergency room and the emergency patients face and challenges indeed patients face in seeking lasting relief. Thank you for joining us, Dr. Ari.
Thank you very much.
You're welcome. Now, let's begin with unpacking what exactly trauma surgery is and what makes it different or unique from other surgeries.
So trauma surgery is a surgery that is done to try and help patients in the setting of the injuries that they may sustain following massive accidents. And the reason why it's different from the other surgeries, most of the time it tends to be an emergency surgery because these are patients who are probably bleeding and you have to stop the bleeding or the patient will die. They may have difficulties in breathing if they have injuries to their chest and their lungs. They could have a brain trauma and their brains are suffering from the injury. There could be bleeding in the brain, and all these things have a time, they are time bound. If something is not done within a very short period of time, then there will be dire consequences.
Yeah. You talk about these mostly being emergencies. Some are bleeding, some have breathing difficulties, others it's brain trauma. So when a patient comes in with such life-threatening injuries, what is your first course of action in those very first few minutes, that critical intervention at that point that is the line between saving this patient's life or you losing that life altogether?
As surgeons, we have developed a protocol which is called the ATLS protocol, and this protocol has a systematic approach as to how you are going to approach these patients. So you want to look at what is the thing that is most likely to cause this patient to die. So the first thing is the airway and the C-spine. So if you are not breathing, your brain can only last only so long, about 7 minutes without oxygen. Beyond that, you will be brain dead. Even if we are able to save you, you will not be able to be a functional person. The other thing is the cervical spine. The cervical spine is the section of the neck where you have the spinal cord. And this one is very important because it supports what we call the vegetative functions of the body. It's the one that communicates to the heart, communicates to the lungs to help you to breathe. So if that one is injured, then again, you have a very short time to live. So you start with the A, you look at those two things. So you look at the airway. Is there anything obviously in the mouth that is stopping the patient from breathing? Are there any fractures around the mouth that are stopping the patient from breathing? Has the patient swallowed their tongue because of the injury? They are unconscious. So you take care of that and you support the C-spine with a hard collar until a time when you are able to do the necessary clinical or radiological investigations that are going to help you to clear the C-spine to know whether it's injured or not.
Yeah. Now, in this country, just concentrating on the Kenyan landscape, what are the most common trauma cases that you've seen presented before you in emergency situations?
The most common as of now, with the proliferation of border borders, they have been helpful in the sense that they have made transportation more accessible, quicker, and even for people who need to avoid maybe traffic and all that. But the downside is that there have been a lot of accidents related to these motorcycles. And I think that has been what has caused the burden of trauma disease in Kenya. So
are you talking about the riders themselves or the passengers as well?
Both.
Okay.
Both. Neither is spared. So these patients will come with various types of injuries, from bone fractures or bone breakages, and also you have patients who have got spinal cord injuries, and these are devastating, life-changing injuries because If somebody has a complete cord injury, this person becomes paralyzed for the rest of their life.
Yeah.
Yeah.
Talking about the boda riders, the spinal cord injuries, because I know it's a huge concern in the country. When you talk about, for instance, spinal cord injuries, Daktari, at that emergency situation, when this patient is brought into the emergency room, can that spine be saved depending on how that patient will be handled at that point?
Sure, for sure, because one of the things you need to do by taking care of the basics, the way we said, you make sure the patient is breathing, you make sure that the patient is having good circulation, they are not bleeding to death. It means, because normally when in the setting of trauma, we have what we call the primary insult, which comes from the direct hit. But thereafter, there's something we call the secondary trauma. This means if the physiology or the things that the tissues in the body that need to survive is not optimized, then you have secondary injury. And also, how you can be able to take care of this is taking care of the basics, as well as if there is a compression and you're able to pick it early, you can take the patient to theater and decompress the cord and try to save as much of the cord that is remaining as possible.
You talked about some of the most common trauma cases being those of boda riders, but how big a problem are motor vehicle, traffic accidents in relation to the trauma incidents you handle?
They are equally common, especially situations whereby pedestrians are hit by motor vehicles. There is a bit of people not being able to adhere to traffic rules, drunk driving, people not observing traffic signs and all that. So it's like number 2 after the boda.
Yeah. Now, before we get into recovery, treatment and healing, beyond accidents, what other causes of trauma are you dealing with on a daily?
You have industrial accidents, people who are working in factories. They may sustain a machine or the equipment may cause trauma. We may also have people falling from heights, especially at construction sites. That is also quite common. Then we have seen also in the neighboring counties where there is a bit of farming going on, you have farm injuries, machinery like the chaff cutters, you find they have injured patients' hands, and so on and so forth.
Yeah. Now, so we've talked about the huge scope of trauma incidents that you deal with in your practice. In terms of challenges, we're talking about a country that perhaps has faced more scrutiny than perhaps other parts of the world in terms of addressing of emergency situations. Sure. Now, challenges of a trauma surgeon, Daktari, in terms of resources, staffing, or infrastructure. When you find yourself in situations perhaps where there's been road carnage, a bus carrying about 24 passengers has been involved in an accident where there's serious trauma in terms of the injuries that patients display. What challenges are trauma surgeons, and particularly you, facing head-on in such incidents?
So even before these patients get to the trauma surgeon, there is also an importance of making sure that they get there in good time. So the emergency services, they may not be very reliable. You find that these patients, when they get injured, they are brought to hospital by well-wishers, in a car, people who are not emergency services responders, so they don't have any basic training on how to handle this patient. And there's a probability that in their goodwill and in their willingness to help, they may cause more damage. But they do it because there are no any good emergency services. Once these patients now arrive in the hospitals, there is generally the ratio you see of doctors to patients. The doctors and the nurses are not enough. And then also the equipment, the theaters that are needed, you find a patient maybe has to wait a number of hours because there are too many of them before they can get a chance to be operated on something that was supposed to be an emergency. So
you've talked about gaps in emergency response. That in itself, of course, being a challenge, but for well-wishers, perhaps for somebody watching, what are some of the must not do. So if you find yourself in a situation where you found perhaps an accident, even a boda rider that is in has been involved in an accident, what are some of the things that should not be done when you're handling this person, irrespective of what their injuries may be, where an accident has been and there's no emergency response, and you find yourself in a situation where you should be the one, or you are the only person that could rush these people to hospital? What not to do?
I think what to do is probably more important, because there are many things that you shouldn't do. What to do is, if for example you are trying to carry a patient who is unconscious, remember we talked about one of the main things that can cause to an immediate death is when you have an injury to the cervical spine.
Yeah.
So these patients need to be transported on a flat surface that is able to support the neck and the head. If these patients have got broken bones and all that, if there is any material that you can use to try and splint the limb, yeah, so that it doesn't go dangling all over, because that one now is causing secondary trauma, you can try and splint these limbs, and also now try and get to the hospital in the quickest way possible.
Right. We talked about in those emergencies, patients coming in, some are bleeding, some have difficulty breathing, some have brain trauma. But looking at a critical care support, right when this patient gets to the hospital, and sometimes you might find that the only thing that is within near reach is a dispensary perhaps, or a very small remote clinic, depending on where the accident happened. How does the availability of blood, for instance, affect whether or not a patient makes it? And we know that in some of these facilities, perhaps there's no blood available because it's perhaps a very remote clinic, very small clinic, and this is the only place that the well-wisher or the emergency response could access. So critical care support, let's talk about that.
So in terms of blood, it's not just even the small facilities, even the large facilities, there are challenges getting blood. Yeah. So I think maybe there is a need to relook in the manner in which we are able to mobilize people to donate for blood. I think that's what is more important, because even the bigger hospitals, that could be a problem.
Yeah.
Yeah.
In cases, again, where there's an emergency, and most of these trauma injuries occur after perhaps emergencies, do we have the capacity as a country, and even perhaps in the facility where you're working, do we have the capacity in terms of specialized healthcare, orthopedic surgeons, trauma surgeons, to meet the demand that you see every day?
I would think general, not just about trauma, in terms general healthcare, the demand by far outstretches the supply of the equipment, of the doctors, and any other resource that is needed to provide for care. Mm-hmm. Yeah.
So in such a case, then, you have a bus load of people that have been involved in an accident. Yeah. And perhaps you, Dr. Kinyua, are the only specialized surgeon that can handle these trauma surgeries, that is able to handle such an emergency. So what happens in such a situation where you have the golden hour, where intervention is key as regards this patient perhaps losing a limb, this patient perhaps even losing their life?
In such a scenario, there are trauma protocols that would help you to decide who is the most needy at this particular hour. Mm-hmm. But you will find that in the end, if you are the only one, then there are so many patients, then there will be adverse outcomes invariably. Mm-hmm. Yeah.
All right. You talked about emergency response being a major concern. You also talked about blood donation, perhaps the need to relook our blood donation policies and drives. In your opinion, what policies, let's begin with policy before we go to societal changes. Yeah. What policy changes would help reduce preventable trauma injuries?
I think there's a strict adherence in health and safety protocols. For example, at construction sites, make sure people have the protective gear, the environment is safe. When it comes to roads, people have to adhere to traffic rules. people have to go to driving school. Most of these border riders, unfortunately, they just finish high school, they just learn how to ride a motorcycle, but they don't really understand the road traffic rules, and this now becomes a problem because they will be driving they will be riding without knowing when to stop, when to give way, and this creates an environment where these accidents happens. So there is need, I think, even not policy or any regulation, is to enforce what we already have. And
Right. Well said. And when we talk about the society as well, because policy is one thing, but when you're told to wear a helmet, you don't put on a helmet. When you're told to put on your seatbelts, when you're told do not drink and drive. So all these, perhaps the policy and the legislation is one thing on the other hand, but the society as well, and the attitude and the complacency when it comes to, rules that have already been enforced, but just the lack of adherence. What can the society do better to help reduce preventable trauma injuries?
I think part of what we are doing, advocacy, you have to keep reminding people, educating people, trying to show them why it's important for them to do what you are telling them to do, to show them that is not just government or institution trying to rein on their freedoms, but rather something that is for their benefit. And also for those who don't adhere, there has to be seen that there are actual consequences in terms of enforcement of the laws. Yeah, those two things.
Right. We've touched on drunk driving, and that's also another key concern in this country, and, also necessitating things such as the alcohol blow because of really the concern over drinking and driving. Now, when you look at trauma injuries or trauma emergencies and look at, the level at which patients that are displaying with these trauma injuries are intoxicated, how would you gauge how serious a concern is drunk driving in this country when you relate it to trauma injuries?
I would say it's a serious concern, because even if you talk to people who work in the emergency departments where they deal with these patients who come with trauma, there's always a surge in such incidences over the weekend, which is not there during the other days of the,
Right, okay, so a surge over the weekend. And also timings as well.
Of course,
you're looking at early morning or?
So normally it's very late into the night and early morning now. Because it takes some time before these patients again are able to get to the hospital. So something that happened at 5 a.m. may take another 2-3 hours before these people are able to get to hospital.
There's something that's closely linked to trauma injuries, which is deformation, facial deformation, perhaps deformation of the head, but a lot of perhaps injury on the jaw, could display itself anywhere on the face or on the skull. In an incident like this, would a trauma surgeon be well equipped to handle restoring the facial features of this patient, or would it be necessary after you've addressed the emergency situation and handled the trauma surgery to call in another expert? Or are you able to handle the restorative element after trauma injuries as well?
So generally, the facial bones are usually dealt with by a special group of surgeons called the maxillofacial surgeons. So these are dentists who have undergone a specialized training, and these are the ones now who deal with the trauma of the face. In cases where there is a disfigurement of the face, then we can even call in the plastic surgeons to come and help do what we call reconstruction and aesthetics, so that at least somebody has a semblance of something that looks like a face, so that they are not they don't undergo stigma in society, they don't feel any inadequacies, which is part now of rehabilitation. But in the initial phase, the maxillofacial surgeon will deal with the initial trauma.
Right. Looking at our capacity as a country in terms of emergency response, especially when we're talking about trauma surgery, what advances or technological innovations have changed the way trauma surgery is being done in the country? Looking perhaps at years back, have there been advancements in terms of trauma response in the country?
I can say that the advances that we have made have actually, you know, in many instances in life, what you need to address are just the basics. You know, now we have trained a lot of orthopedic surgeons. Most of the equipments that are needed to carry out this work are readily available and a little bit more affordable than they were before, because of the technological advances in the East from China and India. You find that certain implants that were quite expensive if they were to be bought from places like the West, UK, America, they are slightly more affordable because of what the Chinese and the Indians are able to do. And,
So, you know, we've talked about pre-hospital management, emergency room responsibility. Let's talk about the management of these injuries. Some of these injuries can be life-altering in the sense that perhaps a limb was lost. Perhaps, you know, we've also talked about the boda riders who might suffer severe spinal injury. In terms of management of injuries, after the surgery has been done, what does that entail?
So if you are successful in saving the limb, the next phase is rehabilitation. They go through physical therapy to try and restore the muscle strength, to restore the movement. In the event that a limb is lost, there is room for what we call prostheses. These are artificial limbs, and they're of various categories. And these ones also help the patient to be able to move around. In the event of the patients who have spinal cord injuries and they are paralyzed, then you have to find alternative ways for them to move around, depending on the level of the paralysis. For example, maybe somebody is just paralyzed the lower part of the body. They have functional hands. Then they can have a wheelchair, maybe that is operated using their hands, and they are able to move around.
You know, and some of these life-changing, life-altering life-altering injuries is what I meant to say. A patient is unconscious and has been brought into the emergency room, and you have to make the decision between whether to save this patient's life by keeping the limb or doing away with the limb altogether. What protocol is used in such situations? Perhaps this is a patient who doesn't have a family member present. They are unconscious. You have to save this life. Perhaps you have to do away with this limb. What protocol would be used in such cases?
So normally in hospitals, you have a legal department, because this now brings about the issue of consent. This patient is not aware of their surroundings, so it's not possible for them to give consent. So the legal department will help you navigate that. In some instances, you can have another surgeon who can co-sign for the patient, because as a doctor, you still owe the patient the duty of care, whether they are conscious or not. So if there is nobody to consent on their behalf, then there are those mechanisms.
Somebody has sent in a question about blunt trauma. Sometimes that may not display physically, but perhaps this patient might be going through internal bleeding. And so when we talk about trauma, most people assume that it's what you can see physically, a broken limb, perhaps a severely disfigured face, a broken arm, but there's that which cannot be seen physically. Let's talk into that, the blunt trauma, and how, as orthopedic surgeons, trauma surgeons, you address that.
So for blunt trauma that is of significant impact, it means it's a major accident, you know. And from the ATLS protocol that we highlighted in the beginning, part of the investigations that are done is that one has to do a chest X-ray, one has to do a FAST, which is a specialized ultrasound for the abdomen and pelvis, or you can do a CT scan, you can do a pelvic X-ray. So with these investigations, you are unlikely to miss any of these blunt trauma. So this tool is quite good, so and it has been effectively implemented in our facilities.
Right, and we'll be moving to the next session of our interview, which will be on arthritis. We invite you to send in your questions around trauma surgery. Do you have a patient? Have you been involved in an emergency situation? What questions would you like to ask Daktari here in terms of trauma response in the country or the management of your injuries? But Daktari, before we close on trauma surgeries, in terms of your checklist as a trauma surgeon, you know, we talked about the equipment that is necessary. We talked about the need for oxygen, the need for blood, and we know that there are certain hospitals in the country that are still incapacitated as regards handling trauma response. What are the must-haves if you're going to say that in an emergency situation, a patient is in safe care?
So basically, you need a team, you need a nurse, you need a doctor, you need another doctor who is going to put the patient to sleep in theater. So you need the human resource capital. You also need the resources in terms of fluids that patient needs to be given. You need blood. There are particular drugs that are necessary to help the patient in dealing with the acute complications of this trauma, and also you need a functioning theater. Yeah. In the event that the patient is severely injured, they may require intensive care after the surgery, or even sometimes they don't need surgery, they just need intensive care.
Yeah.
Yeah.
And final question, Daktari. Yeah. The affordability of some of these procedures. Yeah. We'll talk about the referral hospitals. Perhaps there's hope there in the fact that emergency situations are addressed, you know, for the public. However, when we look at the affordability in terms of what you can do within your capacity and what might need further intervention that might be costly. Let's talk about that, as well as the palliative care for patients who you cannot do anything more for, or who have perhaps gone beyond the threshold of affordability, which leaves you as a surgeon unable to proceed with interventions that could perhaps manage their injuries better or help in terms of their recovery process.
So in terms of affordability, for the most of the surgeries, with now SHA, hoping it continues to work, it's quite affordable because the contributions are not that prohibitive. And in mission hospitals and in public hospitals, and even in some low-level private hospitals, some of these procedures can be conducted and they can be catered for in full or partly by this package of SHA. So that means that a majority of the population can be able to afford in that sense. Right. Yeah.
Okay, thanks for that. I'd like you to close on the trauma surgery before we move into arthritis. And I know you touched a little bit on policy and societal changes that could help prevent such injuries. Yeah. If you had one piece of advice for the public on preventing trauma injuries, yeah, what would that be?
The thing is just to be observant, be able to follow the rules that are laid down. This will be one thing that, because the accidents would greatly decrease if we adhere to the safety and regulations that are there. Yeah.
All right. Now, Daktari, let's now shift from trauma to another area of your practice, which is orthopedics. Many people hear about arthritis but don't fully understand what exactly it is. Help us understand it better.
So arthritis is a generic term or an umbrella term that covers a number of conditions, could be up to 100 of them, whose main manifestation is joint pains, joint stiffness, and joint swelling. In addition, you may have a bit of redness around the joints and warmth. And this is a word that is derived from the Greek words, because the modern civilization as we know it is an improvement from what the Greeks have done. So it's arthros, which means joint, and itis means inflammation. So in medicine, inflammation means that it's a normal body response to any sort of injury, whether the injury is from physical trauma, chemical injury, electrical burns, anything in the body.
Yeah.
Yeah.
So you've touched on it could actually be related to an injury.
Yeah.
Going back to our conversation on trauma surgeries, trauma injuries, have you seen patients starting to display arthritis symptoms after a trauma surgery, perhaps because of the injuries they sustained?
Yes, we have seen that, and it's not because of the surgery, it's mainly because of the trauma itself can injure the joint, because these joints are special organs whose function is to allow movement. The components, part of the components of these special organs is something we call articular cartilage. It is built in such a way that it's supposed to allow a gliding movement that is seamless and smooth.
Right.
But it is avascular, meaning that does not have blood supply. So in the setting of trauma, when it gets injured, it has very limited capacity to regenerate.
Yeah.
So as a consequence, once it is destroyed, you cannot regenerate, cannot come back. And then that now becomes the starting point of arthritis.
Talking about the starting point of arthritis, if you can just show us perhaps, with your limbs or with your fingers, how it displays itself, because there are myths, around arthritis. Oh, I couldn't stretch my knee, I couldn't stretch my fingers. Just a quick description of how it would display, perhaps on the elbow, on the fingers, or anywhere else that you can show us.
So as I said, arthritis is an umbrella term, and under it there are so many conditions, but the common presentation for all of them is that the patient will have joint pains. The patient will have stiffness. That means in the when they start moving, they feel like their joint doesn't want to move.
Yeah.
The other thing is that they'll have swelling, okay? And then they might feel some warmth around their joint because of the inflammation. But depending on what is the type of arthritis, they may have other manifestations. Yeah? So for instance, if somebody has a psoriatic arthritis, they may have skin lesions. Somebody who has rheumatoid arthritis, they may have problems with their kidneys, problem with their lungs, and they may have some nodules that are found. Nodules are swellings that could be anywhere around the soft tissues, around the joints. Okay.
Yeah, and we've seen often people displaying knocked knees as well. Are those some of the myths that perhaps people often associate or would relate to arthritis?
So you can look at them from two perspectives. One, knocked knees, they could be a primary problem in themselves. Somebody was born because of another problem, they have knocked knees. But because of these knocked knees, they can develop arthritis because the loading of the joint becomes abnormal. The transmission of forces across that joint becomes abnormal. Equally, because of arthritis, if it's left for so long, it may destroy the joint in an even manner, so that one side of the joint is destroyed more than the other, and this now will cause the bones to tilt and give you knock knees or bow legs or any other deformities of the limbs.
Right. Dr. Harry, looking at the country, how common is arthritis and who is most affected?
It is quite a common because, as you've seen, there are so many conditions, and equally there are so many joints in the body. So invariably, at some point, somebody will get one of their joints getting one of these conditions. So roughly, we can talk about, one in about 5 or 7, they can get arthritis.
So, old wives' tales tell us that this is an old person's disease, is it?
So, as I said, there are various types of arthritis. One of the most common ones is something we call osteoarthritis, which is a degenerative condition. By degeneration, we mean that the normally functioning tissues are replaced by tissues that are not functioning properly. The osteoarthritis does not have any known cause, but what we have seen is that over time, there are certain risk factors that are associated with it, one of it being old age.
Yeah.
So for that reason, you can get that older people get osteoarthritis. And the reasons for this are several. As I remember I said in the beginning, in the joint you have a specialized tissue that is called cartilage. And this cartilage is formed by specialized cells which are called chondrocytes. And as somebody grows old, the cells accumulate DNA damage. And up to a certain point, these cells will die because they are not functioning properly.
Yeah.
So, yeah.
Okay. In terms of risk factors, what would you say are the main causes of arthritis?
So in addition to old age, we can talk of trauma, as we said before, because once the joint has been damaged, it cannot come back. The other thing is obesity. And obesity affects arthritis twofold. One is that the person is carrying more weight than they should. And this cartilage has a limited capacity as to how much weight they can handle. So if you overload them too much, they are going to get destroyed. Equally, in obesity, there is a lot of fat tissue in the body because the obesity, you accumulate fat. And fat tissue has been shown to be causing inflammation within the body.
Yeah.
And if this inflammation gets to the joint, it will cause destruction of the joint. The other risk factor is manual labor. So manual labor in terms of people who carry heavy things, invariably they are going to, that force is going to go through the joints, or people who use tools repeatedly. You find people like in the village who have been using jembes to farm. You find that they get arthritis of the small joints.
Right.
Yeah.
And you've talked us through the warning signs that someone might be developing arthritis, joint pain, joint swelling, perhaps some redness. But in terms of how this condition affects someone's quality of life on a daily basis, what are we looking at?
Now it depends on how advanced the condition is. In the early phases of the disease, people have mild pain that is not so constant, something that is just a bit nagging, and they are able to go on with life. But as the disease progresses, it can even become something that is stopping them from doing the activity. You'll find somebody in the very advanced stages, they tell you, I cannot even walk 50 meters without taking a break. So this is somebody who cannot even undertake the daily activities of life. They can't go to the market, they can't go to church, they can't go even to do simple tasks for themselves. Yeah.
Diagnosing, let's begin with diagnosing arthritis as well as managing it at the early stages, beginning with diagnosis.
So again, we go back what type of arthritis it is, but in general, the patient has to see a doctor. They have to tell their story to the doctor, and depending on the story they tell the doctor, certain investigations will be required. And the doctor as well will examine the patient to see if there are any signs to suggest what type of arthritis it is. And then the most important investigation in terms of radiology is an X-ray. You look at an X-ray, and from the X-ray you can be able to tell changes that are suggestive of osteoarthritis. Yeah.
Now, Daktari, beyond medication, because obviously there's some medication that would be involved, what lifestyle changes can make a difference for arthritis patients?
So one of them is weight reduction. The other one is quitting smoking, because smoking is a risk factor for osteoarthritis. The other one is regular exercises, because remember the cartilage we talked about, those cells that are found within the cartilage, they have things we call mechanoreceptors. They are able to tell the physical or the mechanical environment in which they are. And these repeated exercises and loading of the joint, they stimulate them to produce more tissues that are necessary to form the cartilage. So exercise is important because also it strengthens the muscles around the joints. They are also very, very key in supporting the joint and preventing unnecessary loading, abnormal forces going through the joint. And in terms of people who may have underlying conditions that are causing osteoarthritis or resulting in arthritis, they need to have those conditions treated.
What would some of those conditions be?
Some of them, for example, diabetes, because diabetes in the long term is going to destroy nerves. If you don't have nerves, one of the things will happen is that the muscles will become weak, and then they cannot support the joint. Another important thing when it comes to nerves is a function, a sensory function we call proprioception.
Yeah.
And this function is important because one is able to tell where their body parts are in relation to the other part of the body, and especially when you're walking. So when somebody is walking, it's a very intuitive process. You don't have to look at the ground to know where you are stepping, because in your mind, because of proprioception, you can know now my foot is about to touch the ground, and you slow down a bit, you don't slap on the ground. So in patients who have their nerves destroyed, they don't know, they are not sure where their feet are, so they have to walk slapping their feet on the ground, and this causes micro-trauma that will accumulate over time and cause damage.
Now, seeing that this condition largely has to do with the joints, at what point would you consider surgery as a possible intervention for a patient with arthritis?
So one of there are three levels at which you can intervene surgically. One, if there is an underlying deformity of the body that is causing an abnormal loading, you can do surgery to try and correct that. Remember, we talked about knock knees or bow legs. If you look at the joint and the arthritis in the joint is maybe affecting only a part of the joint, then you can correct the deformity surgically, so that now the loading in the joint is following what would consider to be normal, and this would halt the progression of the arthritis.
Right.
The other level of intervention is where now the arthritis is so advanced, you need to do a joint replacement so that the joint is completely destroyed, and now you need a replacement of that joint.
Let's talk about the joint replacements in the country in terms of different options, as well as the functionality of that particular limb. If you've got your joint replaced, do you restore full and normal function of that, whether it's the hip or the knee or whatever it is that we're looking at really? Will you restore normal function after that joint replacement? And how common are these joint replacements in the country?
In terms of restoring the normal function, it's not quite possible that the knee that the surgeon gave you will have the same level of functionalities as the one God gave you. So you cannot do extreme sports and things like that, but it quite greatly improves your quality of life. For the basic things that you need to do, there is no limitation. You will go on with your life without pain, and the joint will have similar level of movement. So it greatly improves, but not actually to a level that your joint was there before.
Yeah.
And in terms of options, we can have maybe the joint can be replaced fully depending on the age of the patient, depending on what the underlying problem is. Yeah.
We did not quite get into, when we talk about the joint pain and the joint swelling, and we know that there are people who, because of misdiagnosis, perhaps have lived with these conditions for years. Yeah. Progressively, when you look at arthritis that has not been diagnosed or treated, what are we looking at in terms of eventualities? For instance, can the arthritis itself, if not checked, if not corrected, if not treated, cause a deformity?
For sure, and I think you brought up the issue of knock knees and all that, because as once the cartilage has been destroyed, the next thing below the cartilage is the bone. And the arthritis will not stop at the cartilage. It will continue to the bone and erode the bone. Equally, the other structures in and around the joint, we call them the ligaments, which support the joint. They are also not spared. So if this arthritis is allowed to continue for so long, the ligaments will also be destroyed. And then now the joint become unstable, and that now will result in deformities. So if left untreated, invariably you will have deformities as a consequence.
Now, the biggest misconceptions, Dr. around arthritis that you'd like to clear up, I told you the most common is the fact that it's an old man's disease. But generally around arthritis, some of the myths that you'd like to clear that are in the public domain.
Some of them involved or revolve about the surgeries that are done. There are people who believed that maybe because one person somewhere had a surgery, every surgery has complications. So you find that everybody believes that you will be worse off if you have surgery than before. But what studies have shown us, and these are things that have even been replicated locally, is that with surgery, you can, up to 90% satisfaction rate in our patients. So they are quite happy. But there's always that one story that travels far and wide.
Now, the need for physical or occupational therapy as you're managing whatever type of arthritis it is this necessary for each individual case?
In the early stages, whatever the arthritis you have, I think physical therapy is quite helpful in trying to slow down the progression of the disease. Because with physical therapy, you are able to improve the mobility of the patient. The patient can be able to walk more. And how this helps is that, remember we said the chondrocytes that make and maintain the cartilage have mechanoreceptors, and they are quite responsive to what we call physiologic loading. So it means that with physio, you are trying to maintain the cartilage that is left or that has not been destroyed. Equally, you are strengthening the muscles. Remember we said the importance, the role that muscles play in terms of supporting the joint, making sure that there are no abnormal forces going through the joints.
Healing, is this a lifelong challenge that a patient would have to bear in terms of treatment? Does it progressively stop at some point? And assistive devices as well that could make life easier for this patient and daily tasks easier for this patient. Let's talk about treatment. Depending on the arthritis that one has been diagnosed with, are we looking at a lifetime of treatment?
It's more of a lifetime of management, because sometimes treatment would imply that you're able to restore things to the way they were before. So
I suppose what I'm asking is it curable?
No.
Entirely?
No, you cannot, because cure would mean, you see, cartilage has very little capacity to regenerate. So once you've lost it, you've lost it. So whatever we do is to try and make sure that you don't lose more of it. So the physical therapy, the medication, the weight loss, all these things, they have to be done for a lifetime so that you slow down or halt the progression at the point where you are.
In terms of supportive aids? In
terms of supporting aids, for example, in knee arthritis, you have braces which help support the knee. Sometimes somebody can be given a cane, for example, for the hip. Somebody walks with a cane so that part of the weight is carried by the cane, part of the weight is carried by the joint, so that one again tries to slow down the progression of the condition.
Now, for a viewer who has a patient or a loved one that has arthritis, has perhaps managed it over the years, how to manage those symptoms, and even if this person is perhaps on some therapies, some treatment, what to do right at home to relieve the discomfort or the pain?
So I think most importantly is that these are patients who are supposed to be on follow-up with doctors, so that now they are educated on the things that they need to do depending on the arthritis. If, for example, is the group of arthritis that we call inflammatory, seropositive or seronegative arthropathy, they tend to get worse when it's cold. So these patients can try and keep warm. And then at home, again, they can be able to take the medication that they are given. At home, they can avoid activities that overload their joints, and so on and so forth.
And Dr. Ari, final question now from our viewers. How can I live as normal a life as possible, even after being diagnosed with arthritis?
If you are adherent to treatment and also depending on your level of disease, that will help alleviate the symptoms. So it's adherence to treatment, adherence to the things that the doctor advised, the weight loss, stopping smoking, taking the medication, doing physical therapy, and so on and so forth.
I'll give you a minute to give us your winding remarks. This morning we've been talking about the world of orthopedic and trauma surgery, you know, split decisions that could save lives after devastating accidents. We also zeroed in on arthritis, which is a reality that many people in this country and globally are facing in this day and age. Dr. Ari, your parting remarks as we close.
So to our viewers at home, I would like to encourage them whenever they have any joint problems, it's always good to seek treatment promptly, because this will mean that the disease is caught at an early stage, whereby very simple interventions are going to help prolong the life of your joint. So don't sit with it at home. And in terms of trauma and trauma surgery, is that you can always get help. Try and get to a nearby facility in good time, and you can get very good results if the right thing is done at the right time.
And Dr. John Kinyua, where can we find you?
You can find me in Kenai Spine in Thika. I also do consultations with Nairobi Women's Hospital and various other hospitals in town.
Right. We thank you so much for your time. Dr. John Kinyua is an orthopedic and trauma surgeon, and we wish you a lovely day. I'm Lillian Muli. We'll see you later.